Okay, thank you. Let me start my experience with the Hoya Vivinix IOL. And I've been using their lenses almost now, touching 3 years plus, maybe 4 years now. And I've been with them for a very, very long time in terms of doing an analysis of their patients. No financial disclosure. We had various generation of IOLs, and we are looked into premium IOLs, the IOL designs, and its real relationship to the posterior capsule in terms of decreasing the opacity to the posterior capsule, which is a major concern for all of us for patients' benefit in terms of long-term clarity of capsule is concerned. So this Vivinix lens with the surface modification is aimed towards decreasing the posterior capsular opacification, and maybe it will decrease the requirement of YAG capsulotomy or delay the requirement of YAG capsulotomy in future. And we all know how it works and its mechanism of getting the posterior capsule towards the posterior surface IOL by with the modification of posterior surface only of this IOL with the ozone treatment. That is how it's going to work. And they have modified their other areas of interest, that is the haptic is texture. Similarly, their edge of lens is also textured so that you have a better orientation during your insertion of a haptic, as well as it has a better alignment or a contact to the capsular bag for a better fixation also, which is going to be a remarkable addition for their toric designs in the future also. This is how high magnification their lens looks like. Let me talk about my own experience with the Hoya lenses, where we looked into the posterior capsule dynamics towards the posterior surface of IOL with these lenses in the long term, and correlate that to a quality of vision with these patients subsequently. Just briefly show my one of the video here. Do a routine surgery for these cases. The rexis is around the same size as you do for other cases. My rexis is around 5.2 to 5.5 in all these cases. And centration of rexis is very, very important. I strongly feel the rexis has to be 5 millimeter or plus in all these Hoya Vivinix lenses. Unlike the other lenses where rexis can be little smaller also, because they came out with the ICERT 251 earlier, which was little smaller in diameter. The rexis side had to be little smaller in those cases. The phaco can be completed. Let me just show you the insertion of a lens here. Once I complete my emulsification and remove the cortex asset. And the cortical removal and posterior capsular cleaning is also utmost important here, because you can't leave any fibers there, because that's going to get attached to the posterior surface of the lens. And absolutely clarity of capsule is mandatory for these cases. The lens insertion is very, very easy with their device. It goes through 2.2 inside the anterior chamber. And situation where you have a difficulty, like you have a small pupil or a little bit of bag dialysis, this lens can be injected very, very safely inside. And you can rotate your cartridge in a way the haptic goes behind the capsular axis. And you can see this in high magnification, the texture, their haptic, which never gets attached to the, or gets plugged to the optics of the IOL, which is the beauty of this lens. And it snugly fits into the capsular bag beautifully. This is towards the end. And just to show you what relationship it will have towards end with the capsule here, I've completed and just looking into the capsule and the posterior surface of the IOL here. This is the posterior surface of the IOL. This is the capsule here, which is a little wavy because the capsule will be a little loose after we remove the entire bulk or nucleus. And as soon as we hydrate the nucleus, the capsule goes backwards. See, this capsule is absolutely clean and well taught. So this is the configuration we like to see for most cases subsequently. We looked into a posterior capsular configuration in a post-op period in a day 1, day 3 months and 1 year, and then assess them in terms of quality of vision by eye trace and posterior capsule. Also look for any changes in the lens as such. So we had an average patient with a 54 age, around 77 eyes of bilateral surgery. Now we have almost more than 200 cases enrolled now. Visual acuity wise, they are very good. No intra-op complications. We had a clean posterior capsule in a day 1 for both patients. Looking into type of a posterior capsule, wavy pattern we saw in almost 41% and smooth pattern in a 60% of cases. And the distance from the lens to a posterior capsule was around 200 microns on a day one. If you see here, day one, that some cases the distance was less. But if you see this patient at day 30, the distance had decreased. At day 90, it has already got attached to the posterior surface of the IOL. So this is another patient, day one, and this is day 90. And this is day one. You can still see a taut posterior capsule. At day 30, this is the clarity of a posterior capsule, and day 90 is almost attached to the posterior capsule here. This is day one, a wavy type of posterior capsule, and this is at day 30. And this is what sometimes you see, wavy pattern, as we saw in a 41% of cases. This is a taut pattern in around 60% of cases. At 1 year, around 67% cases, we had a complete adhesion of a posterior capsule towards the posterior surface of the IOL. And these patients, looking into their configuration, the smooth configuration was there in these cases. That means if you have a smooth configuration from a day one, the chances of addition of a capsule towards a posterior capsule is much higher. So around 82%, 88% of cases where PC were there in day one, and they got towards the end of 1 year. Around 50% we had a wavy pattern, but they got adherent at 1 year. And the significance was, as I said, wavy had slightly less adhesion to the posterior capsule. So this is what we can see here at decrease in the height of the capsule from the posterior capsule, which goes on changing from a day one to 1 year also. So it's not that every capsule will get attached to a posterior surface of the IOL. So there is a definite difference in a type of pattern we see in these cases. Looking into their visual quality, also we found that if you have a complete addition, the quality of vision was better in terms of Stell's ratio, MTF values, and RMS value. They were better than those cases where the capsule was not adherent to the posterior surface of the IOL. And also, if you look into other areas, they are correlated. If you have a capsule, the distance capsule from the posterior surface less, the quality vision was better. Only 2 cases had a little bit of a central, you can say, growth. Otherwise, all cases at 1 year was absolutely clear posterior capsule. No patient required YAG capsulotomy till date. My experience now 3 year plus. We have not done YAG for any patient as such. And none of the cases had a glistening as such in these cases. Some cases, we have reported this also, had a little bit of a cellular growth, like epithelial cells or growing onto the periphery of the lens in these cases without having inflammatory signs. We checked their AC cell flare meter. They didn't have any cells in flare, but they did have a cells. And they were appearing around 3 months to 6 months subsequently. And these cells never grew towards the center. They were in relation to the capsule only. So we don't know what is exactly the theory behind why these cells are growing onto the surface. Maybe because we think that there's some sort of surface alternation apart from the posterior surface. Something goes on the anterior surface also, because it is the fibronectin reaction which is happening in the posterior capsule and IOL. That is how it is getting attached. The same thing maybe spill over to the anterior part of a capsule also, and cells may be migrating anteriorly also. But capsule are well adherent, and no PCO was seen in these patients also. So these are, some cases out of 200, I think we had 11 patients having this. But if you dilate all patients, there will be some specks of cells seen, which is true with all hydrophobic lenses. This lens has slightly more than other hydrophobic lenses. To summarize, I think the posterior capsular pattern from a day one is important, which will decide the addition of a capsule towards a posterior surface of the IOL. And if you have an addition, if you have less distance between the posterior capsule and the posterior surface of the IOL, the quality of vision is far better than those cases where the capsule is far away. And in terms of posterior capsular opacification, it did not make a difference. But yes, the quality of vision was definitely better with the addition. Therefore, the concept of modifying the posterior surface of the eyewear and getting posterior capsule attached seems to be absolutely correct, because it is found that quality of vision will definitely better in these cases. We need to see them long term. Now our follow-up is touching 3 years. Maybe it will give us to see the opportunity of incidence of YAG capsulotomy in these patients. Thank you for your kind listening, sir.
Thank you very much, Dr. Titiyal.